My talk this evening will be on CMC joint replacement, and thank you all for being here. I know several of you are coming from far away and from different time zones. Thank you for joining. This is going to be sort of introduction to CMC joint replacement. I know this is a controversial topic, especially in the Anglo-Saxon world. I'll show you some of my experiences, and I hope to convince you at the end that it is at least a valid treatment alternative for this common problem. Because from wherever in the world that you are watching, you will see patients in your clinic with painful CMC joint arthritis that have failed symptomatic treatment and that are coming to you for further advice. And for the first 4 or 5 years of my career, I did what I was trained to do, meaning that a young active laborer would get an arthrodesis and all the others get a trapeziectomy with the ligament reconstruction. But it really never was my favorite operation. The results were good, but it took a long time for patients to recover. Many had pain for several months. Many did not fully regain function. And there was a significant number of patients who were really not happy with the outcome. I feel this is reflected in the literature, and this is probably the most quoted paper on CMC joint replacement. It's a prospective study coming from Nottingham, published in 1997, comparing simple trapeziectomy with trapeziectomy in tendon interposition and trapeziectomy with ligament reconstruction. And if you look at the figures, there's less than 50% of patients are really without pain or restrictions. And if you look at the figures for stiffness and for weakness, there is a significant number of patients who still complained of stiffness and of weakness. This is another paper coming from the Netherlands. It's a 5-year follow-up study on 2 different techniques following trapeziectomy, one with a bone tunnel and one with a pure ligament reconstruction. This is a very busy slide, and you don't need to look at all the figures. Just look at this. If the patients were asked if they would have the same operation again after 12 months, 1 out of 3 patients said they would not have the procedure again. And after 5 years, still 1 out of 5, around 20% of patients said they would not have the procedure again. That's not just a little bit unhappy, that's really unhappy about the outcome of the procedure. And this has convinced me to start doing arthroplasties for these patients. There was a surgeon in town who was doing it for several years, and I started about 15 years ago. I saw his patients. They seemed to do better than my trapeziectomy patients. I was very hesitant in the beginning, but now it is by far my preferred operation for this pathology. Now, if you look at the outcome of implant arthroplasty, I think there's 3 very important factors. That's the choice of the implant, it's the selection of the patient, and it's the surgical technique. We need to pay credit to this man, Jean-Yves de la Cafetière. We would not be doing what we do now without this man. He started using this CMC prosthesis, developed it in the 1970s, that's 50 years ago. His prosthesis has gone through an evolution, but it's the start of what we use today. Several prostheses have been put on the market, and I will not give you the results and the outcome of each of them. Most of them have been retracted, but all of these have paved the way to what we are using now and to the prostheses that I think are giving us good outcome results now. What is the gold standard at the moment? Based on 10-year follow-up studies, it's an uncemented modular implant, a metal on polyethylene ball and socket joint. So a modular implant, and it can be single or dual mobility. Second is patient selection. What is our indication? It's stage 2 and 3 CMC osteoarthritis with sufficient trapezial height, and that also includes the shape of the trapezium. We don't want to do this in very dysplastic trapeziums who have failed conservative treatment. And if there's any doubt, we'll take an X-ray and we'll take a CT scan to look at the trapezium and to see if that trapezium will take a prosthesis, yes or no, and to counsel the patient on what we're going to do. And whatever we do, if we start doing an arthroplasty, we always have the option to change the plan and to go to a trapeziectomy when something unexpected would occur during the procedure. But I'll come back to that later. There's some relative contraindications. Generalized joint laxity is a relative contraindication. There is definitely more instability problems with patients with joint laxity. Osteoporosis can be a relative contraindication. You need these are press fit, hydroxyapatite coated implants, so you want them to be well fit into the bone. High activity level is a relative contraindication. We've done this in high activity patients, but they're a minority. And then asymptomatic STT osteoarthritis. So symptomatic STT osteoarthritis, we'll exclude those and we'll do a trapeziectomy. If patients have STT arthritis, but it's asymptomatic and that's based on clinical examination, there is proof also in the literature that they do well and they don't complain of STT problems. And the third is the surgical technique, the third factor. This is a technically demanding procedure, and almost every complication that you see early on, being instability, early loosening, and pain, are caused by technical errors during the surgery. And what are those technical errors? The most common is malpositioning of the components, as you can see here. Sometimes it's not easy because there's not much room for error, and some of the trapeziums can be really narrow, and you need to fit in a 9mm trapezial cup. So you'll need to use fluoroscopy during the procedure to very precisely position the cup in the center of the trapezium to get a good outcome. Another complication is trapezium fractures. Most of them will occur during the surgery, and you will need to notice them. If you don't notice them, you will have a loose cup and problems afterwards. And a third common problem is impingement, because osteophytes were not resected. And if you leave osteophytes such as this one in place, these patients will have impingement, which will be painful, and it is a significant risk of instability because of contact with the osteophyte. So it's a technically demanding procedure, and there is a learning curve. The learning curve, how long is it? Probably around 30 patients. This is an interesting paper. They published 10-year results on a CMC joint replacement, and the survival rate was 85% at 10 years and 80% at 15 years. But if they excluded the first 30 cases, the survival rate significantly increased with 92 at 10 years and 85% at 15 years. So there is a learning curve, no doubt, and you will have to go through that. You have the option, if a problem occurs, to transfer the plan to trapeziectomy, and it's going to take you around 30 cases before you can really be confident about the long-term results. Because that's what we want. We want well-centered implants, both in the trapezium and the metacarpal. We want no osteophytes and no impingement, and a good range of motion of the joint. How is it done? My preferred approach is a dorsal approach. It's centered between the EPL and the EPB tendon over the anatomical snuff box, and it runs from the artery centrally over to the base of the first metacarpal. I'll show you a video. This is the incision. We'll take sensory branches of the radial nerve out of position, and the first thing we'll do then is to isolate the radial artery, which is in danger when you're incising the capsule. I make a longitudinal incision in this along in the same position, in line with the skin incision, and then I'll make two flaps that will take the capsule off the base of the first metacarpal. And this is a minimal approach. There are surgeons that do a far bigger release of tissue around the metacarpal, which I think is unnecessary. The next step is resection of the base of the first metacarpal, and typically we'll resect 2 to 3 millimeters, and then we'll resect just the cortex, and very important, the osteophytes that are present at the trapezium. There's almost always an important osteophyte between the first and the second metacarpal that needs to be removed because it will cause impingement and can be the cause of instability. So all the osteophytes need to be removed, which gives you this situation. Again, these are the cuts. So it's a minimal cut at the base, 2 to 3 millimeters, and a minimal cut at the trapezium in line, parallel to the cut of the first metacarpal when it is held in 20 degrees of abduction. I feel that's the right plane to make the cut and to position the trapezial implant. So here, if we make the cut on the trapezium, we'll keep the thumb in 20 degrees of abduction, and then we'll make a minimal cut, just a sliver of cortex, but the osteophytes that are present. And this is the situation you want to end up. We check fluoroscopy to be sure that there's no remaining osteophytes, and we have two parallel cuts with the component in place here for the metacarpal. This has to be avoided absolutely. If there is a remaining osteophyte at the base of the first metacarpal, at the volar side, you need to remove this because this can cause impingement, pain, and instability. So you need to remove it as it was done here. You need to check for that on fluoroscopy, as it may not be fully clear when you're doing the surgery. Again, this is what we want. Resection of all osteophytes, all bone, and well-centered implants. And we'll use an offset neck. Most of the systems will give you the opportunity to put a straight neck or an offset neck. We looked at this in 3D, looking at normal thumbs, and it feels much more natural to put an offset neck in. It's like we would put a straight neck in a hip arthroplasty. You would never do that. Well, it's the offset neck that fits best in a normal anatomy. So I feel that's the better option. The next step, you've made the cut, is reaming and making place for the implants. And the first reaming is done on the metacarpal. It helps a lot to put the wrist on a towel so that you can keep the wrist in ulnar deviation to get an easier approach on, into the first metacarpal. It's shown here. All the systems, all the instruments are very similar. So there's rasps that come in different sizes. The size of the component for the first metacarpal is determined by the bone quality much more than the size of the metacarpal. So once it is well fixed, and you hear that it gives you a different sound when you're reaming, when you're putting the broach in. If you hear that sound that it's catching well and it's stable, then that's the right size. You don't want to go for the biggest size possible because you might end up stuck halfway. And loosening of the metacarpal component is not a problem. This is no reason to absolutely put the biggest stem in there. So this is absolutely to be avoided, and this can happen if you breach it too big and you've made room for a big implant, then you want to put that implant in and you get stuck and it stains out, and of course this is going to be a disaster afterwards, and too much tension and loosening of the cup. And you want to put the stem in completely so that if you need to do a trapeziectomy later on, you can leave the stem in place. These are very difficult to remove, and if we do revision, we'll tend to leave this the stem in place. We'll take the cup out and we'll take the neck out, but we'll leave the stem in place. So you want it to be well seated into the first metacarpal. Now the position of the cup, and that's absolutely the critical step in the procedure. Everything is easy so far, but this is difficult because you have only one chance to position it well, and you want it to be exactly in the center, or you have biomechanical problems and risk of instability or loosening if you put it too eccentric. So we'll keep the thumb again in 20 degrees of abduction, and then we'll center it, and that's going to be the place where I want my cup positioned. We'll use a hemostat and check it under fluoroscopy so that we have the center point, and then we'll ream again along the axis of the first metacarpal so that the component can be positioned in that position where we want it to be. Again, there's not much room for error. This is usually you have about 3-4 millimeters on each side, but some of the trapeziums can be very small, and you need to be very precise positioning this, and absolutely use fluoroscopy to help you. And then the next step is reaming in that position in line with the first metacarpal. And then the cup is inserted. I think almost every system that's on the market now has hydroxyapatite cups, be it spherical or conical, and then there's no strong arguments to use either a spherical or a conical shaped cup. It's impacted and it needs to be stable, and we'll check if it's really stable before we continue. And it has to be flush with the trapezium in line with the first metacarpal. We'll do a trial reduction, and these necks come in different sizes with most of companies with 2 millimeter increments, and you want it to be absolutely stable before you continue. Now that can be a problem. So sometimes I do a very limited release. As I said, some surgeons do bigger releases, which give you a better access to the trapezium. But of course, a bigger release means more surgery, more bleeding, probably more pain, more fibrosis. So I try to limit the approach as much as possible. But sometimes I have a restricted access to the trapezium, and then we asked our technical department to make an adapted reamer so that we can do it almost like minimally invasive, still get a good access at the right angle without the big release that is necessary. This has been a very useful tool in my practice, and I think if our technical department can make this, I think that can be made in every hospital. And then the next step, if you're happy with the components and with the position and with the tension, the final component for the metacarpal is inserted. This is again a hydroxyapatite coated. I put a suture around the implant. I learned that from our shoulder surgeons, which is going to help me with the reinsertion of the capsule. It's inserted, it's well seated. The head is mounted, and this is a single mobility cup. I'll show you later that we now have dual mobility cups also, and the advantages it has. And then with those sutures, it's very easy to restore the capsule and to fix it onto the base of the first metacarpal. Now, I don't think that's really important, and stability really depends on the implant position and on the tension more than on the capsule closure, but at least it looks nice when it's closed well. And then the skin is closed. Now, this is a dual mobility, and I think most surgeons who do joint replacement for the TMC joint will now use a dual mobility. The only difference is that the polyethylene is now on the head and is not fixed into the cup. But apart from that, it doesn't change the surgical approach much. Checking stability is really important. Whatever prosthesis you use, it will take it to a full range of motion, make sure there's no impediment, and we'll try to lever it out, and it has to be 100% stable, which it usually is if you've positioned the components in the right position. What's the aftercare? They get a compressive dressing with a splint for 2 weeks, and after 2 weeks, we see them back in clinic. And this is not unusual. So a large number of patients are almost pain-free at 2 weeks and have good range of motion. You can see the stitches have just been removed. Yeah? They can start using their hand from then on, and we give them a splint, a brace to wear in between for another 4 weeks. Just for, I think it's more for ourselves than for the patients, because they're really comfortable and they start using the hand, and almost everybody is completely pain-free at 6 weeks, which is a big difference when we compare it to the trapeziectomy patients, at least in my experience. Now, why, if you're watching this, and probably many of you will not have experience with this prosthesis, why would you start doing it? And I'll try to give you a couple of reasons. One is it's absolutely less painful compared to resection arthroplasty. The majority of patients have no or minimal pain after 2 weeks, and here you see another one at 2 weeks follow-up. So almost no swelling, full range of motion, and almost no pain. The second reason is if you compare in studies that have compared trapeziectomy with prosthesis, almost all of them show an earlier and better return to function, looking at range of motion and strength following prosthesis. And let me point out at one. This is a study that compared a trapeziectomy with joint prosthesis. Pinch strength and range of motion were superior in the prosthesis group. And one factor that seems to contribute to this is the MCP hyperextension. They stated that the MCP hyperextension appeared to be prevented in the prosthesis group, but increased over the follow-up period in the LRTI group. And this is a patient of mine. The left hand was treated with a prosthesis, and the right hand was treated with a trapeziectomy and ligament reconstruction. They had the same degree of osteoarthritis, the same deformity preoperatively, and you can see the difference and how a prosthesis can restore length and alignment of the thumb better than trapeziectomy, and so probably provide for better range of motion and pinch than the trapezectomy. Again, the Lacafeniere already pointed at the importance of length and restoring length to restore function as one of the big advantages of a prosthesis compared to trapezectomy. And he showed that there is a constant relationship between the length of the second ray and the length of the first ray. It's about 0.79 for females and 0.81 in males. So you can easily measure that now with the PACS device systems that we have available, and it will guide you as to before surgery how much lengthening that patient might need to restore his alignment of the thumb if he has a MCP hyperextension secondary to an adduction contracture of the first metacarpal. And length is essential, very important, and you can easily over lengthen. So we'll always check length once the trial implants are in. Make sure that the patient has full passive flexion of the MCP and the IP joint of the thumb, and we'll put a little mark on the index finger to confirm that we've not over lengthened the patient. This is a study that's specifically looked at the outcome of total joint replacement and that the correction of a MCP hyperextension. And for them, what they showed was about 30 degrees is the limit. And if you have less than 30 degrees of hyperextension, many of the patients were corrected by restoring length with a prosthesis. And of the 26 patients that had a reducible Z deformity, which is shown on the left, only 5 were not totally corrected following arthroplasty. And that's also been my experience. And I feel that probably one of the reasons why these patients are happier than trapezectomy patients. This is a patient of mine with a long follow-up. She had an important adduction contracture and about 45 to 50 degrees hyperextension at the MCP joint. We did a total joint replacement and a simple volar plate capsulodesis. This is her at 6 weeks, and this is her alignment at 5 years with a well-aligned thumb functioning without pain. And this would be very difficult to get this alignment with trapezectomy, I feel, in my experience. The third reason is that the reported long-term outcome of some implants is good. And we have several studies now that have shown 10-year follow-up results. Just to quote a few, 10 years with different prostheses, but all a very similar design. Modular hydroxyapatite coated cementless implants with a ball and socket joint and with a spherical or a conical cup. And we'll look at one in more detail. This is the survival curve of this patient group, 199 patients with a minimum follow-up of 10 years. And you see there is 92 survival rate at 10 years. And on radiographs, 93 of the patients show no signs of loosening on radiographs. Also looking at VAS scores, DASH scores, and key pinch at 10 years follow-up remained excellent results with almost no pain, a very low DASH score, and good key pinch compared to preoperatively. And if we compare these outcome series with the Nordic hip register for hip replacements, the results are very similar. And I know, and you're all aware, a register is not comparable to a case series. And we don't have good registers for these prostheses. And I'm sure if you would have a register, the results would be less good. These are very experienced surgeons who do a lot of them and have good outcome. So I'm sure with the register, we would have less. But at least it shows that we are coming close to the survival of hip replacements with these prostheses, at least in experienced hands and with the right prosthesis. And the fourth, which is probably for me one of the most important reasons, if it fails, there is still the option to do a trapezectomy, and the outcome will be very similar when you compare it to primary trapezectomy. And that's been shown in a paper published in the Journal of Hand Surgery in 2013, where they looked at the outcome of primary trapezectomy versus secondary trapezectomy following a failed prosthesis, and they showed that the results did not differ from the primary trapezectomy results. So that gives us the option, if something would fail, then we can do this, and at least we've given that patient probably for 10 to 15 years of function, and then we can turn it to trapeziectomy. There's definitely some disadvantages, important disadvantages. It's a more expensive implant, and it will depend on your social security system. If you are allowed to use it, it's more expensive than doing trapeziectomies. And it has, and that comes out of every paper that is published, it has a much higher complication rate compared to trapeziectomy. So if you're doing this 5, 10, 15 times a year, probably you shouldn't be doing this. There is a learning curve, and it has a high complication rate. So you need the experience and the attention to detail to get good results. As said, many of the early complications are due to technical problems during the surgery, which can be a fracture of the trapezium. It can be pain because of impingement or because of over distraction. If you over lengthen the thumb because you've done a big release of the capsule and you need the over distraction to make it stable, then there is a risk of pain and problems with motion of the thumb. There is a very low, but there is a risk of infection, and some cases have been reported. And the most important problem, instability, what we're all afraid of because of malposition of the components or because of impingement. And then the good news is that this was our biggest concern, instability following total joint replacement. And even if we thought we'd done everything well, we had a instability percentage of about 3-4% following this procedure. Now that has changed with the use of dual mobility cups. It's a bigger head, which significantly decreases, and a lot of research has been done on this in the hip arthroplasty world. There seems, and all the papers that published on this, there does not seem to be a higher risk of polyethylene wear, and some of the newer devices have extra cross-linked high quality polyethylene now, and it definitely significantly increases the stability. One very experienced surgeon, Shuruk Dishian, published his results with a single mobility device and had a dislocation rate of 7.3%, and the same surgeon with a somewhat different device and a dual mobility cup, the dislocation rate decreased to 0.5%. So at least if you start doing this, definitely you go for dual mobility cups. It will significantly decrease the risk of instability. A paper from my Belgian colleagues who looked at meta-analysis, who looked at the late complications and the reasons for revision. And number one, of course, is aseptic loosening. Instability can be a late problem also. If we see it late, it's because of polyethylene wear or because of post-traumatic causes. But loosening is the biggest problem, and no surprise, it's the cup that's really the problem. It's rare to see loosening of the stem. It's the cup, and there's probably some improvement that can be made there in cup fixation. So in conclusion, I hope I've shown you that total joint arthroplasty can at least be a valid treatment alternative for CMC joint arthritis. The pros and cons are very clear. It's going to give your patients a quicker return to function, but it comes with a higher complication rate, and you will need to discuss with the patient what you're going for. And we now have several implants that have good 10-year follow-up, almost as good as the hip replacements. Now, if you have gained an interest in this, please go to the website of the Belgian Hand Group. The Belgian Hand Group, under the presidency of Anne Lejeune, has organized a congress last year on total joint replacement. Several excellent speakers on all different aspects of this treatment, and they're all free, available on the YouTube channel of the Belgian Hand Group. All right, thank you for your attention.